What I'm going to talk about is actually all the whys, the who, the what, where of related to our study. And our study was using implementation science to promote the use of fascial iliacal blocks in hip fracture care. So we're talking about the what and the why. Now, we know that FI blocks are a part of one of the 15 quality standards for hip fracture care, and that when we did an audit, we realized we were suboptimal performers with respect to this quality standard. And of course, we wanted to deliver the highest quality of care and to reinforce and foster a culture of quality of care. So we looked to the health quality standard. We focused on quality standard number 3, multimodal analgesia, which is considering the use of non-opioids such as an NSAID, and of course the providing peripheral nerve blocks in fracture to help manage fracture hip pain. And why would we consider that as an intervention and an important intervention? We know that most hip fractures occur in older adults. More than 30% are greater or equal to 85 years old. And that with an aging population, we have a medically more complex population to care for. And older adults are more vulnerable to adverse events, and 1 in 5 experience a complication. And we have a 1-year mortality rate of greater than 25% in our elder population. That hip fracture pain is very severe, and that pain control in the elderly population or anybody with a hip fracture is paramount. Opiates are known to be associated with considerable many adverse events, including delirium, respiratory depression, constipation, pneumonia, and ileus. So we looked at using this knowledge to action wheel. Our no to gap then was the health quality Ontario standard for the management of hip fracture pain. And then it was standard number 3, multimodal approach, including fascial iliac blocks or peripheral nerve blocks. And an audit showed that we were suboptimal in our performance rates for the delivery of fascial iliac blocks at St. Michael's Hospital. And although we had a policy existed, it didn't ensure that actual access to this intervention for patients. Our project goals were to increase the number of patients greater than the age of 50 presenting to the emergency department at St. Michael's Hospital and the delivery of a fascial iliac block within 12 hours of a diagnosis. We wanted to improve our patient outcomes through effective interprofessional collaboration and comprehensive engagement of our stakeholder groups across the transitions and care for our fractured hip patients, and utilize rigor during our implementation endeavors, and settled on using implementation science methodology to enhance practice change. So in our endeavors, we interviewed 25 staff members and coming from the various departments, including the emergency department, orthopedics, anesthesia, and geriatrics. We did 5 patient caregiver dyad interviews, and we had site observations in the ED anesthesia, our regional room. This is where peripheral nerve blocks are administered, and our orthopedic units. Interview guides were developed using the CIFR tool. And so you can select your key constructs of interest for both populations, and they were modified for staff surveys and for our patient and caregiver interviews. And we use a framework approach regarded for barriers and facilitator analysis. And then we mapped and developed evidence-based intervention strategies from that data. Example of some of the barriers and were a lack of standard process to coordinate the delivery of the blocks with the regional room. Another barrier was that the delivery of the fascial block is reliant on the healthcare provider initiative and memory. There was no formal process for them to do this. And from a patient and caregiver perspective, there was difficulty for them to make healthcare decisions while experiencing the severity of a hip fracture pain. Here's an overview of the number of barriers and facilitators that barriers particularly that we observed. And 10 was the highest, and that had to do with the actual clinical environment. And then 8 barriers were related to creating and the distribution of education materials, and 8 with identifying and use local opinion leaders, 5 with around using champions, and 2 audit and to provide feedback dimension, and of course prepare patients to be active participants, and then train staff on F1 block procedures, and then 1 block around the notion of changing and mandating change. So our number 1 priority was the environment. It had 10 barriers. We had no pre-existing standard clinical pathway, and it became evident that this needed to occur first as a first priority. So now when a patient comes to the emergency department and is diagnosed with a hip fracture, at any point in time, if the ED physician is trained, they can provide a fascial iliac block. And in order to improve that, we created a list of trained MDs for the RNs to also support and advocate for their patients. They actually didn't know who could and would do blocks in the emergency department. And we ensured that those kits, F1 block kits, and the medication were available within the emergency department. An alternative pathway is that after hours, the orthopedic surgeons, once they are informed that this patient has a hip fracture, they can actually call the acute pain service. And the anesthetist can actually administer the block either in the room or defer to the operating room if it's after hours. Also, during the weekdays, the pathway is quite clear that every day we get a notification from the fracture liaison coordinator that sends an email first thing in the morning, 7:30, to the pain service and then to geriatrics. Previously, it was usually geriatrics because we already had an automatic referral process for hip fractures and geriatrics. And we would call the anesthetists and they didn't have a room. And we would say, this patient really needs a block. And so now it is, they are informed well in advance of this patient. And we now have a dedicated space in the regional room for them to perform this. And they, and again, can do it either in the regional room or in the operating room as well. Create and distribute our educational materials to staff. So we created it, and then of course we took it back to the users and got their feedback and kept modifying this until we got the tools appropriate and based on their feedback for staff. And we also did the same thing with patients and caregivers, and you can see the difference. And in making sure that what they felt they needed, the information they needed to make informed decisions about this information was appropriate for them. So how did we empower and motivate and educate? Well, we engaged our patient family education specialist, especially with the patient caregiver tool, and she made sure that we had appropriate language. And with that tool, we engaged our ED ortho unit educators to be part of that process, and more champions, engaged patient family tools, and we engaged the patient and family in the tool development. We engaged RN staff in tool development. We engaged the managers and IT with regarding the standard operating procedures and electronic health record order set development, and which led to patient tool empowers the EDRNs to discuss F1 blocks with the patients, and that the geriatric CNS, myself, educates actually the ortho educators on the unit, because some people actually may not be in the emergency department. They may get actually transitioned to the floor, and we wanted those that staff and the educators to also advocate. So now we have a list of trained ED physicians to facilitate the block delivery in the emergency department and advocacy on the RN's part. We have onboarding tools and resources created for the EDRNs, and a process created for delivering the F1 blocks after hours and on weekends. So we looked at all of those strategies that came out of mapping of our barriers facilitators to intervention strategies. It was environmental restructuring. We implemented that. The education got implemented. Our enablement, we implemented persuasion, which was to collect and analyze and distribute our performance data on fascial iliac block, and of course, training staff on peripheral nerve blocks procedures. So our outcomes, so what did we see? We did see an increase in fascial iliac block from 48 to 65%. The time to F1 block was also, it was decreased from 1.63 to 0.81. We saw a decrease in delirium from 43 to 34%. We did not see necessarily a change in opioid use or pneumonia. And with pneumonia, it could be skewed because we were at the beginning of COVID when we were kind of looking at data and so forth. So we had COVID, and so that might have factored into some of those that outcome measure. The message is, don't drop the ball. Once you've done these things, you can't take your eye off the ball. You need to constantly reinforce to motivate. You need to identify those champions and educate the new learners. We often think that if you don't you do a one-off and that sticks, but people are moving. We particularly know that nurses change, they come and go, and other people come and go. And so we need to routinely also reinforce what best practice is and be those champions. Continuous quality improvement. And so you need to continually monitor and evaluate and modify those gaps in order to sustain your implementation.